This is a general orientation for the Regional Quality Council members, otherwise known as RQC. This general orientation is offered to council members as an overview of the Regional Quality Council. Additional targeted training and/or in-services may be conducted during conference-type settings, meetings, or via tangible materials made available to members. Thank you for participating in the RQC in your region. For this orientation, there is no test, just vital information that will orient you as to what the RQC is, describe how to make this a meaningful experience, and it will be a handy reference during your term. Please complete your review of the information at your own pace, but prior to your next meeting. This is an overview, and additional presentations are provided to council members. There are also annual trainings or meetings that can be expected to take a deeper dive into the topics that are noted in this overview. The information in this overview will include the definition and purpose of RQC, expectations of council participants, structure of the quality improvement committees and quality management program at DBHDS, the quality concepts and quality improvement models, along with tools that may be utilized by council members to participate in QI planning and initiatives, and key performance areas of focus identified to be addressed by DBHDS. Quality assurance, risk management, and quality improvement are integrated processes that are the foundation of the quality management system at DBHDS. There's a set level of quality that is expected. This is called compliance. It's referred to as the quality ceiling. And up to that point, you're looking at quality assurance, reviewing and assessing regional and state data to identify any trends, question findings, and see if additional steps are needed, and assessing for and ensuring compliance with regulatory demands. Once you reach the ceiling, everything beyond that is considered quality improvement, where you're striving for improvement in whatever it is you're working with. At DBHDS, quality assurance and risk management fall together under the Division of Compliance, Legislative, and Regulatory Affairs. There are two subsections. One is the Office of Human Rights, which looks at compliance with human rights regulations, human dignity, advocacy, and managing human rights dispute resolution programs. There's also the Office of Licensing. The Office of Licensing is the regulatory authority for licensed service delivery system across the state. The quality improvement aspect at DBHDS falls under the Division of Chief Clinical Officer and then under Clinical Quality Management. There you'll find the Office of Community Quality Improvement as well as all of the quality committees. The Office of Clinical Quality Improvement provides technical assistance and consultation to internal and external state partners and licensed community-based partners. It facilitates the use of data in the quality improvement process to identify trends. It supports all DBHDS quality committees in the establishment of quality improvement initiatives and develops training resources for quality improvement. The office provides oversight, either directly or indirectly, of quality service reviews through the National Core Indicators, Quality Service Reviews, and Support Coordinator Quality Reviews. Here you can get a visual of the quality improvement structure in relationship to the various committees, work groups, regional quality councils, and the Quality Improvement Committee. The Quality Improvement Committee is also known as QIC. It's the highest level quality committee for the agency and has oversight of the quality management program. All other quality committees report into QIC, including the regional quality councils, and they're all known as subcommittees to the QIC. The QIC ensures a process of continuous quality improvement and maintains responsibility for prioritization of needs and work areas. The Quality Improvement Committee also maintains a charter and ensures that all subcommittees have a charter describing standard operating procedures. QIC also ensures that providers, community service boards, and other stakeholders are informed of quality improvement initiatives approved for implementation. The other committees include the Regional Quality Councils, Risk Management Review Committee, Mortality Review Committee, the Case Management Steering Committee, and 3 key performance area work groups, which we'll discuss later in this presentation. So, what are RQCs? RQC stands for Regional Quality Council. These are subcommittees of the Quality Improvement Committee, and they have the support of DBHDS leadership and operate within each region of the Commonwealth. They review information from a quality perspective and target efforts to improve quality at that regional level. These councils all fall under the oversight of the Office of Community Quality Improvement. As a reminder, quality assurance pertains to meeting rules, regulations, and statutes, while quality improvement is continuing to work to improve beyond what the actual requirements say you must do. And this is a diagram to demonstrate this. The main focus of the RQCs is to identify and address risks of harm, ensure the efficiency, accessibility, and quality of services to meet individual needs in integrated settings. It's also to evaluate data to identify and respond to trends and ensure continuous quality improvement. There's an RQC in each of the 5 regions of the Commonwealth, and these groups meet to discuss specific regional issues in order to give recommendations to the QIC. All members and alternates attend within their specific region on a quarterly basis. The quality improvement specialists are noted in this organizational chart on the bottom row. These people are the chair members of the RQC meetings and the primary contacts for RQC members. Their contact information will be located at the end of this presentation for your convenience. The department has identified 3 key performance areas. These are known as KPAs, and they are areas of focus that align with the mission, vision, focus, and strategic plan of DBHDS. There's a work group for each of these areas, and those were the ones shown in the quality structure diagram earlier in this presentation. Within these 3 areas, there are 8 domains, as seen here. There are 2 outcomes related to the health, safety, and well-being KPA. The first is that for individuals, people being served are safe, receive routine preventative health care, and holistic person-centered behavioral health services and supports. The second outcome for this KPA is related to engagement of communities. Communities work together to address health-related issues that are identified and prioritized by DBHDS, as indicated through the mechanisms such as Behavioral Health Index and others, to promote well-being, to achieve positive health impact and outcomes through the provision of training opportunities, support for coalition capacity building, and leveraging community resources to enact environmental changes that support the social, emotional, spiritual, and physical well-being of individuals served. The domains that are included in this KPA include safety and freedom from harm, physical, mental, and behavioral health and well-being, and avoiding crisis. The outcome related to community inclusion and integration KPA is that people have opportunities to engage in community-based activities that support socialization, employment, recreation, and personal development for the purpose of building and strengthening relationships with others in their local community. The domains included in this KPA are stability, choice and self-determination, and community inclusion. The provider capacity and competency KPA outcome is described as having enough providers who are knowledgeable, trained, and experienced in our network to ensure equitable and timely access to supports and services. The domains which are included in this KPA are access to services for people with developmental disabilities and provider capacity and competency. Performance measure indicators are also known as PMIs, and these are measurable statements that are used to show progress with a specific target. An example could be 86% of people receiving DD services through the waiver report satisfaction with those services. That's just an example, not an actual PMI currently being evaluated. There must be at least one PMI that's assigned for each of the 8 domains, and these must be formally approved by the QIC. Assuring compliance with rules and regulations, such as those imposed by CMS, is another purpose of the PMIs. Performance measure indicators include both outcome and output measures that are established by the DBHDS and reviewed by the DBHDS QIC. The performance measure indicators allow for tracking the efficacy of preventative, corrective, and improvement initiatives. DBHDS uses these PMIs to identify systemic weaknesses or deficiencies and recommends and prioritizes quality improvement initiatives to address identified issues for QIC review. Data is collected related to the PMIs, and this information gets reviewed and analyzed by various subcommittees and the KPA work groups. This information is presented to the RQCs for review and for their recommendations as well. KPA work groups and subcommittees can propose PMIs, and RQCs can propose a PMI if they are submitting a quality improvement initiative to the QIC. All recommendations must go to the Quality Improvement Committee for further consideration. So to summarize the KPA structure, there are 3 areas of focus known as key performance areas. There are 8 domains which have been divided among those KPAs, and these domains are aligned with the DBHDS mission, vision, and strategic plan. They're also aligned with the settlement agreement which is currently in effect. For each domain, there's at least one PMI, which is a performance measure indicator. These PMIs must be approved by the Quality Improvement Committee. To further facilitate informational flow, each RQC has a member identified as the RQC liaison to the Quality Improvement Committee. The liaison attends the Quality Improvement Committee meetings, reports any recommendations or concerns from their RQC's perspective, and brings that information back to their RQC from the Quality Improvement Committee meeting. DBHDS staff who attend QIC are also a part of the Regional Quality Council meetings. and there's an assigned quality improvement specialist in each region that supports the RQCs and acts as a chair on the council. The QI subcommittees provide reports to the RQCs and to the Quality Improvement Committee. Regarding meetings and membership of the regional quality councils, charters establish the purpose, role, and responsibility of the council. While nominations may come from a variety of sources, members and alternates are approved by the DBHDS Quality Improvement Committee prior to serving. Terms for all members are at least 3-year commitments, and regular attendance and input is required. This is the member's opportunity to provide input, and attendance is a critical component of the process. Meeting attendance may be in the form of phone or video conferencing due to travel constraints, and meetings are typically scheduled for 2 hours once a quarter. Members that are unable to attend should contact their alternate member and the council chairperson as soon as possible. Contact information for the DBHDS QI specialist, which serves as the chairperson for each specific region, will follow later in this presentation. According to the RQC Charter, membership on the council must include a residential, employment, and day services provider, a Community Services Board Developmental Services Director, 2 support coordinators or case managers, a Community Services Board Quality Assurance or Improvement staff member, a private provider quality assurance or improvement staff member, a crisis services provider, an individual receiving services or who is on the developmental disability waiver wait list, and 2 family members of individuals receiving services or family members of individuals that are on the wait list. There are also assigned DBHDS staff in the form of the Director of Community Quality Improvement or designee, a Quality Improvement Specialist that also serves as the Council Chair, and the Regional Community Resources Consultant. For each of these positions, there is also an alternate member that is noted. All alternates are encouraged to attend the meetings to stay abreast of current information being presented in case they're needed to act as a voting member in the absence of the member and to ensure a quorum is present at each meeting. Alternates serve a very important role and participate by providing input into all planning and discussions. Although if an issue is brought to a vote, only the main voting members are polled. There must be a quorum of at least 60% of members for each meeting. The quorum includes members from each of the following roles. There must be a member of the DBHDS QIC present. There must be an individual experienced in data analysis present. There must be a developmental disability DD service provider. And there must be an individual receiving services on the wait list or a family member of an individual receiving services or who is on the wait list. If all of these pieces are met, then the quorum is met for the meeting. As previously mentioned, each RQC will appoint a non-DBHDS member to act as a regional liaison to the QIC. The RQC liaison is responsible for attending Quality Improvement Committee meetings, reporting regional recommendations, and reporting results of quality improvement initiatives. The RQC liaisons are vital members of not only the RQC, but also the Quality Improvement Committee, being the people able to convey information from one group to the other in a concise manner. It's important to have a liaison that was present at the Regional Quality Council meeting to present to the Quality Improvement Committee, and for this reason, there's an alternate liaison named for each RQC. As a member of the RQC, you play a vital role in the quality improvement oversight of the Commonwealth. Your opinion and input is both requested and respected. As external stakeholders, council members assist DBHDS by bringing their particular perspective when reviewing data and making recommendations. The council is only as good as its members and their level of participation. In order for council members to be effective, they must play an active role both during meetings and when preparing for meetings. This would include reviewing information and data prior to meetings, being prepared to discuss your personal findings and compare those findings with findings from other council members, working together to identify priority items within your area, and developing plans to address the needs the group has identified. Council members are also asked to help distribute information from the RQC to their prospective programs, agencies, and families. This is not a forum for individual issues or grievances. This is a forum for discussing system-level issues identified within the data. A quality council relies on people bringing an open and sometimes skeptical mind to the discussion, not specific agendas. There are several quality management tools that are used in organizations that may include charts, data, graphs, etc. Two common tools used are root cause analysis, which is also known as the 5 whys, and fishbone diagramming. One way to identify a problem is to use a root cause analysis and ask and answer the why question as a series of answers. Try to do this at least 5 times, saying, why did something happen? Then why did that happen? And continue this until you can go no further. This is also known as the 5 whys and enables you to drill down to the true cause of a problem, and that way you can more accurately address a systemic issue. It also can show you a simpler solution to what you thought was a complicated situation. Another problem-solving tool is a fishbone diagram, and it looks at the cause and effect of issues that are hindering your improvement. You may find that there's more than one reason why something happened, or that the reasons fall into separate categories and the cause begins to branch as you answer the why questions. This method looks at various categories of causes to help the reviewer narrow the scope of focus. Once the specific areas of a problem are identified, then you could go back to using the 5 whys to determine what truly is the issue. The 5 whys and the fishbone diagrams are just two of many quality tools that are used in the identification of an aim statement and can also be helpful during the study portion of the PDSA cycle. The model for improvement begins with 3 fundamental questions. The first is your aim. What are we trying to accomplish? You must know what your objective is and what change you want to see when the improvement project is complete. Be able to explain why what is currently taking place is not working, and a good aim addresses an issue that is important to those involved. It's specific, measurable, and addresses the questions of how good must it be, by when, and for who. So think in terms of measure it, how much time, and what population it's important for. Some examples of some not so useful aim statements might be, we'll do better on tests. Instead, you could say, every member of our study group will increase his or her grade point average by 10% or more in 8 months. Or another non-useful statement, I will lose weight. Instead, you could say, I will weigh 160 pounds or less by February 1st. The second question is, how do we know that a change is an improvement? This is considered the measure. You need to know how you can determine that there has been an improvement. What are you going to see that will prove to you that things are working as you want or as you expected? The third question is, what change can we make that will result in improvement? And this is your change. You have to determine what actions you believe would lead to that improvement. Once you've identified the answers to those first 3 questions, you can test your identified changes using the PDSA cycle. The cycle of PDSA allows for continuous improvement regardless of the current level of functioning. For example, if you're already doing well with your goal, this will not only be identified during that cycle, but other opportunities to improve upon those results will still be present. If you're not doing well meeting a performance measure, this will be discovered during the PDSA cycle too, and you'll be able to address your results and determine future actions. During the cycle, you can determine whether to adapt to what is found, adopt the change, or discard it and begin again. The PDSA cycle is used to test changes you feel will improve quality. You need to make sure that your objective is clear and measurable in the planning stage. You must be able to determine if progress is being made or not, and how you will know this should be identified during this stage as well. Identify the who, what, when, where, why, and how so that your goal is concise and your action steps are clear. Identify if there are current data sources, both internal and external, that could be utilized, and determine if additional data will be needed. Also, make sure that the data that you're collecting is purposeful. Will it be used? If not, there's no use collecting it, and your efforts should be focused on another data set. When you're planning your action steps, effectiveness and efficiency should always be made a priority. You don't want to waste time spinning wheels to accomplish a goal, and the action steps you take should be deliberate and focused so you can evaluate them later in the cycle. Identify strengths to build upon and barriers to complete the task at hand. You take a look at the strengths in a situation in order to allow you to focus on things that are already working well and either don't need to change or only need to be improved upon. Remember the saying, don't throw the baby out with the bathwater, meaning if it's working, build on it and don't recreate the wheel. Looking at the barriers also enables you to get a full picture of what will be required to accomplish a task, and if it's even a possibility. It may identify prerequisite steps that are important or reveal that the task isn't necessary in the first place. Also, identify low-hanging fruit items. In the planning stage, you need to determine the level of effort action steps will require and the resulting impact of those steps. Don't waste time on things that take a lot of work and won't result in an equal or greater impact. The sweet spot is the actions that are fairly easy to attain, don't require a lot of resources, and will result in a sizable change. This is what is referred to as low-hanging fruit, and it's generally an easy task to complete and to build upon to improve your quality. During the do portion of PDSA, you're carrying out the plan, observing and describing what happens, and collecting meaningful data. It's very important that the data is meaningful. There's no need to collect data that you're not going to use or that means nothing to this quality improvement process. It ends up wasting valuable time and discouraging those putting in the work. Document any problems or unexpected observations during this time, and also an analysis of data can begin during this stage. The data that you collect needs to be accurate. Remember, it's not what you think, it's what you know based on the data. And trash in equals trash out, which means poor data equals misleading reports, and actions taken based on these reports are not beneficial to anyone. RQCs typically review quantitative data to assess quality. This means the data contains a quantity or a measurement of something, and this number may be compared to the desired quantity or the targeted goal. Quantitative data can also be compared across regions, services, even states when the same data points are collected in other areas. Quantitative data is number driven. It may include total numbers, percentages of a whole, or even more complex data, such as rate of improvement or decline. Here's a very simplistic example of data analysis regarding the productivity of two employees, Bob and Sally. The employees are all expected to complete 95% of their work assignments daily. Bob is given 10 assignments, but Sally works in a different department, and she's given 15. Bob consistently completes all 10 of his assignments daily, but Sally only completes 11 of hers. Bob's completion rate is at 100%, while Sally's, even though she's completed more assignments in total, is only at 73% of what is expected of her each day. Bob is meeting expectations, while Sally is not. So keep in mind that even though Sally's completing more assignments than Bob, her expectation is greater, and therefore she's only completing 73% of her work every day. A key point in quantitative data analysis is the old adage, compare apples to apples and not apples to oranges. This is important to keep in mind when identifying what data will be collected and when reviewing data reports. For example, what assignments are being completed and are they comparable to each other? For the study portion of PDSA, you're analyzing the data pertaining to the measure. Remember to take that data at face value and don't read anything into it. Compare the outcomes to the predictions. Was it what you expected? Why or why not? What did the results tell you? What did you learn? And did you achieve the desired results? Although RQCs may be involved in all steps of the PDSA cycle, they are involved in this step by reviewing the data and determining what it means to them. Data analysis is the cleaning of data, making sure it's accurate and relevant, and extracting the useful information. Decisions can then be made using that data. Many times the data will already have some analysis completed, and the council is analyzing the analysis. You need to identify big issues that can compromise the data and balance your review by taking into consideration other sources of information. Some examples of data analysis might be measuring and comparing compliance rates, comparing quantities of events or items, and reviewing the quality of work. As a caution, do not generalize the findings beyond their limits. Do not make assumptions and take that data at face value. And do not jump to conclusions without checking other sources. The final piece to the PDSA cycle is acting. After taking the data for what it's worth, a decision must be made based on the results. Are you going to adapt, adopt, or discard what you tested? You need to decide what comes next and make needed changes. How will you refine the change based on what you have learned? Is there another emerging trend or problem that also needs to be addressed? This step is where you would determine if the intervention was successful and where recommendations may be made based on the information reviewed. Successes should always be replicated or expanded upon. This information and any recommendations made by the RQCs is then presented to the DBHDS QIC to further review and determine next steps to take. This could include a new quality improvement initiative, or the Regional Quality Council may also decide to take on a project within their region based on their findings. This is also the time when you decide if you're going to start another cycle with what you have learned. Once the first cycle of PDSA is complete, the information and recommendations are utilized to start the next cycle in the planning stage. The cycle can begin again because there's almost always room for improvement. But at the end of the cycle, you have to decide to either embed the reform you created or refine it through a new plan if the aim hasn't been met. This is how the process is deemed continuous, and it's vital for quality improvement. Eventually, the successful changes become a part of common practices. Thank you for your representation on the Regional Quality Council, and we look forward to working with you in the future. Please refer to the following slide and contact your Regional Quality Improvement Specialist with any questions you may have. They are there to assist you and to support the RQCs. If you're participating in this in-service independently, please contact your Regional Quality Improvement Specialist to discuss any questions you have related to the material. Afterwards, please take a moment to complete the 5-question survey at the link listed prior to the next RQC meeting. Completion of the survey is only used to record and track completion of the orientation overview, and training dates are required for our records. If you have problems accessing or completing the survey in any way, please contact your regional QI specialist and they will be glad to assist you and record your answers via phone or email. As promised, here's the contact information for the DBHDS QI specialist serving as the RQC chairs listed by region. Again, representatives should contact them with any questions, as well as to discuss attendance issues and nominations for the committee. Thank you again for volunteering your time to the RQC in your area.